Now? Should have sound? Yeah? You don't hear?
That's the output volume.
Here, we have sound. We have sound. You should be hearing in a second. I think you will hear in a sec. Yeah, sound is working. Hi, guys. I'm here with Barbara Scott, and we're delighted to have this seminar. Thank you for your patience, and yeah, we're very excited to have this seminar with a very talented and very knowledgeable reflexology expert. And this is the third seminar we're having with Barbara, and it's all about male fertility. So I'm especially interested today.
That's very reassuring.
Cool. So yeah, I'll let you take it away. And let us know if there are any technical issues. And guys, please send questions in the comments because we'll answer them.
Okay, lovely. Thank you. Well, I'd like to say welcome to you all for joining us. And also a big thank you to Watkins for hosting another webinar, our third webinar. A big thank you to Eitan for sorting out all the technical things and also for allowing us to do this. A thank you to Lucia, who's been sorting out all of the process of helping you to join the webinar, and also to Harriet, who's here with me this evening. She's going to be dealing with your questions. So before we start, just to say you will receive an email this evening which will contain all your special offers. So I think there is a 50% discount on the book again, which is absolutely fantastic and very generous of Watkins. And also there'll be a code for you to use if you want to book onto any courses. And that will give you £20 discount on any of the courses. But as I say, all of that information will come out to all of you who've registered in an email, I think, which goes out at about 10 o'clock this evening. So, to start, we're going to talk about male fertility. Male fertility is an absolute passion of mine because, in the main, it is marginalised by traditional general medicine. Most of our males are ignored when it comes to thinking about fertility, and the focus tends to be on our women. And that means that we miss a lot of the clues as to what might be causing a problem in terms of fertility. Causal factors are a third male, a third female, and a third joint. That means that our males are involved in 50% of the issues that are affecting fertility, certainly here in the UK, and that is replicated around the world. So it is something that we really need to focus on. In addition to that, male fertility is really in decline, and we are going to talk about that as we go through the evening. Now you should be able to see the PowerPoint I'm going to share with you. Okay, so the things we're going to be looking at are some of the points you need to ponder when you are addressing male fertility, and that doesn't matter whether it's you as an individual or whether it's you as a practitioner working with clients who are having difficulties. We're also going to look at some of the most current and up-to-date World Health Organization reference ranges for semen analysis. And we're going to look at additional tests that are available for semen analysis, because the most that we will be thinking about is looking, most of your clients will be looking at a basic semen analysis, but there are lots of other tests that will tell us an awful lot about our male clients, that will help them to continue to conceive naturally rather than to have intervention. So again, we will talk about that later on. And then we have an updated male treatment protocols. There are 2 of them for you. Both of these have come from the book. So as you will understand, there is a lot more information about male fertility in the book, but we're just going to give you a little overview of what you might need to be considering when you are treating males. One of the first things to say, and the thing that I hear most from practitioners, is men are very reluctant to engage in treatment. So one of the reasons that we have designed the initial consultation process is so that we can engage males in treatment. Now, an initial consultation, I think we've spoken about this during previous webinars, means that what we do is consultation only. There is no treatment during that process. It's about finding out what is happening for your clients, so where they are, how they got there, and what we can do to move things forward. What that also allows us to do in terms of males is engage with them, explain what we're doing, explain how we work, explain what reflexology has to offer, and explain what it can and cannot do. And that then means, because men like really tangible things, it allows them to ask questions and actually then allows them to engage with reflexology. So it is a great tool to use specifically with our men. Okay, so some points to ponder. Most fertility clinics still focus on female fertility issues. They are still focusing on the female carrying the baby, and therefore they presume that the issues still lie with the female rather than the male. And as I was saying previously, what we know is that males are involved in approximately 50% of all cases of fertility issues. So we really need to engage our males in this process, and probably up until the point that they come to see you, they will have been ignored other than just providing a straightforward sample. When we're looking at a semen analysis, okay, we're looking the other end of the telescope. So when clients are referred to a fertility clinic, they are just looking to see whether they've got sufficient number of sperm and whether they're going to have to use either IVF or ICSI. They are not promoting natural conception, and that is really what we are about. Clearly, if we have to support clients through IVF or ICSI, then we do that as well, but the primary focus is to support them in helping them to conceive naturally. What we know is that IVF is a very demanding form of treatment to go through. It places a lot of pressure on couples, and if you can do just one thing that will help to prevent them going down that path, then you'll have done an amazing thing as a practitioner. Okay, so we are talking about promoting natural conception. As I said already, approximately 50% of cases of infertility are attributable to male causal factors, and that is key because we need to find out what might be causing those issues with male fertility. Just some things again for you to think about. So in the 1930s, average sperm counts were 120 million sperm per milliliter. By the 1990s, that had halved to 6. That's a huge reduction, and people always ask at this stage what might have caused that, and the causal factors are various. So we have a number of things going on. We have men who are more stressed. We have estrogen that has got into our water system via the oral contraceptive pill. We have a food system that contains pesticides, xenobiotics, so cleaning substances we're being exposed to. A lot of phytoestrogens, which also have an impact. So phytoestrogens are plant-based estrogens. The main one is soya. Soya gets into our food system in all kinds of things: breads, pastries, pasta, etc. It's used as a thickening agent, and we know that that can have an impact upon male fertility because it is a natural estrogen. So it's really important to be aware that male fertility has declined, and actually what you will see is that filters through to the World Health Organization reference ranges in terms of semen analysis. So also in the 1930s, less than 20% of men had a sperm count of less than 40 million per mil. By the 1990s, that had doubled to 40% of men having an issue with lowered sperm count. So what we can see is in that 60 years, sperm counts, or semen quality, sperm quality, had reduced significantly. And we really do need to factor this in. Most men do not realise Men don't like talking about sperm. Harriet and I had a really interesting meeting with a wonderful man called Richard Westerby, who supports couples who are going through surrogacy, and they went through that themselves to have their twins. And one of the things he was saying that they found very difficult was actually saying the word sperm and talking about it. And it's one of the most important things that we actually engage with men and get them talking about their fertility and not feeling quite so uncomfortable about it. If you ever listen to Professor Sheena Lewis, who has developed the sperm comet test, which we are going to talk about later on, one of the first things she says when she's speaking in public is sperm. There, I've said it, I've said the word, because we do need to get rid of all of the uncomfortableness in talking to men about their sperm. It's really key. We need to make it less of a taboo subject. Okay, so as we've been saying, male fertility has declined by approximately 50% in the last 25 years. That is a huge reduction, and it isn't just in the UK, that seems to be replicated around the world. And one of the very interesting things that we're starting to see now is in the developing countries like India and China, as they are starting to take on a more westernised diet, which comes with affluence, their levels of fertility are declining. So basically all their traditional foods that they're eating, which were keeping them very healthy and were very good for fertility, and now they're developing a westernised diet, and we're seeing lots of fast food being eaten. It's having a huge impact upon their levels of fertility, so really important to be aware of that. So the two studies that actually show very clearly this decline were a French study and a Danish study. So the French study, 26,600 healthy men studied between 1989 and 2005, and what you'll be able to see is that the sperm counts fell from 73.6 million per male to 49.9, and a Danish study from 1930 to 1990 replicated that decline. So we're seeing, clearly not just here in the UK, but that seems to be being replicated in many other places. Okay. The other thing to be aware of is even the most detailed of semen analysis are only able to determine a visual viability of the sperm. So basically what they're doing is they're taking a sample of the sample number of the sperm, and they're looking at them under computerized microscope, and they're looking visually at the sperm. It doesn't actually tell them anything about the content of the sperm. What it tells them is how many are there, how well formed are they, so the morphology, so have they got 3 tails or 2 heads, or malformed heads or mid-piece, etc. But it doesn't tell them anything about the content. So the sperm comet test, which has been developed by Professor Sheena Lewis, looks at the content of the sperm head. And what is in the content of the sperm head, or what the sperm head contains rather, is the DNA. So those lovely strands of DNA. Now, if that DNA is fragmented, so it has lots of little breaks in it, then it means that beyond a certain percentage, it's likely to cause or be a contributing factor in repeated non-implantation, failed IVF and ICSI cycles, and early miscarriage. So you can have males with a perfectly normal semen analysis, producing lots of lovely sperm, and they all look absolutely fine and they're swimming well, but you can have very poor DNA or elevated levels of sperm DNA fragmentation, which can cause problems with this. So we usually say that if you have couples and they've been trying to conceive for a couple of years, or they've had repeated failed IVF cycles, or a number of early miscarriages, and I mean really sort of within the first few weeks, there may only be 5 or 6 weeks, but that's happened a couple of times, then we refer our male clients on for sperm comet testing, because quite often that is an issue, and there are things that can be done to improve it using reflexology and or diet, nutrition and lifestyle changes. Right. So these are really good tools for us to have as a reproductive reflexologist, because what we know is that if we send clients for a semen analysis and it is poor, we can work with them for a period of time and repeat the tests, and you will see all of the parameters changing, improving. So that's what makes it so fascinating, because here we have integrative medicine working very, very well together. Okay, so I want to look at some of the current World Health Organization reference ranges for a semen analysis. One of the things to say before we start this is that if you have couples presenting for treatment and they are under 35, if they have been trying to conceive for a year, then they are nice guidelines. So recommendations for testing is that they can present for a semen analysis, a basic semen analysis, via their GP, and it will give some idea of what is happening. It is very basic, but it will give us some idea of just what the sperm look like and how well they're moving and how well formed they are. If they are over 35, then the guidelines are that they only have to wait 6 months. However, these are very basic tests and they only tell us a certain amount. And if you have someone with a more complex picture, then it would make sense to send them for a more detailed semen analysis. And if you're based in London, you have Andrology Solutions and Dr. Cheryl Homer, who is very happy for us to refer clients to her for a very detailed semen analysis, which provides a lot more information. And certainly if they've had a more complex picture in terms of repeated failed cycles, repeated miscarriage, or they've been trying for 2 years with absolutely no success at all, then we would recommend that they have a sperm comet test. So, volume is the first thing that they look at in a basic semen analysis. So actually the volume of the seminal fluid that's produced. And the World Health Organization now recommends that the reference range for this should be between 1.5 and 4 mils. So if you have a male who has produced a sample that is only 1 mil or slightly less, then either he hasn't managed to catch all of the ejaculate, and let's face it, this is a difficult thing to do for men, or it means that there is an obstruction of some kind, and it certainly would be worth a repeat test. If you have a male who has produced more than 4 mils, and I'm talking probably 6, 7, 8 mils, then it may be that there is contamination of some kind. There might be a prostate issue, or there might be some other issue, an infection present, etc. And again, it would need further investigation. Initial count, so it's counting the number of sperm that there are, should be greater than 15 million sperm per milliliter. I'm going to come on and talk about that in a little bit more detail in a moment. And then we're looking at motility, so how well the sperm, on how many numbers of sperm are moving, progressively and non-progressively. So that means that they need to be moving in a linear, straightforward, not kind of, hovering on the spot, but a combination of both. It should be greater than 40% of the sperm are actually moving, but progressively, which means moving forward, so not going around in circles or hovering backwards or shimmying around, should be greater than 32% of the sperm should be moving progressively for this to be qualified as a good sample. We need to have a total motile count of greater than 39 million sperm per ejaculate, and they need to be 58% of them as live. So the vitality, which means live sperm, should be greater than 58%. Normal forms means how many of them are normally formed, and this is really interesting. So the reference range is now 4%. And what that means is that 96% of the sperm can be abnormally formed for this to be classified as a normal sample. When I first started in practice, it was 20% normal forms. It then reduced to 15%, then 9 to 11%, and it's now 4%. So what you can see is that actually mirrors the progression of poor sperm quality. So we now have males with 96% of their sperm poorly formed, so therefore of no use whatsoever, and that would be classed as borderline normal. Okay, tells us an awful lot about what's happening with sperm quality. pH of the sperm should be greater than 7.2%, but we're going to come on again and talk about that. So it should be an alkaline sample. Okay. We need to look at the volume of the seminal fluid, and you might come across, if you're looking at semen analysis results, you might come across some of these forms of terminology. So aspermia means that no semen has been produced, and clearly that's going to have a huge impact upon your couple's ability to get pregnant, because if they're not producing any sperm, then they're not going to get pregnant. So it could be retrograde ejaculation, or it could be an obstruction or a blockage. So most men will know that this is what's happening, and it can be really worrying for them, and they most certainly need to be referred on for further investigation to find out what is happening for them, because if it's an obstruction or a blockage, or it's an infection of some kind, it could be something that can be reversed or treated medically, and therefore it means they could then go on to achieve a natural conception. Hypospermia, that is a volume less than 0.5 mil. So we were talking about the reference range being 1.5 to 4 mils. If it's less than 0.5, then obstruction, infection of the prostate, we know that probably 90% of seminal fluid is produced by the prostate. So if there's a prostate issue, it could mean that it's causing a problem with sperm volume. Or it could be a problem with the seminal vesicle. Okay, so again, that needs to be formally and medically investigated. It's not for us to investigate these. We can do some supportive work in treating them, but there needs to be formal medical investigation. What we need to be as practitioners is really well informed about what our clients are going through. So all of this information is about you as practitioners being well informed and understanding what is happening for your male clients. Okay, so hyperspermia is a volume greater than 6 mils, and again, contamination due to infection, inflammation, again possibly from the prostate. So this would need further investigation, again not by us. If you do live in and around London, you are very lucky to have Dr. Cheryl Homer, who is probably one of the only practitioners who does this kind of work in such detail with male clients, and she is great. She's great for us as practitioners to be able to refer to. Okay. So, initial count, which needs to be greater than 15 ml per milliliter. So, what you need to remember with this is that the initial count will depend upon the volume of sperm that has been produced. So, if you have a male who's only produced 2 milliliters of seminal fluid, then he needs to have produced a minimum of 30 million sperm. So 2 times 15, 30 million. If he's produced 3 million, it would be 45 million. Okay, so you need to bear that in mind. So let's have a look at some of the possible causes of poor sperm counts. These are things for you to contemplate. We've already spoken about some of them. So they could be environmental. We've talked about what male sperm may be being affected by. So we have, as we were saying, estrogens in our water caused by the oral contraceptive pill. Great for women because it gave us such freedom and gave us more life choices, but it's not been good in terms of fertility. What they've also recently discovered is there are a lot of, there's been an increase in the prescription of mental health drugs, so antidepressants, they're now finding molecules of this in our water system and are now having to find ways of getting rid of that. Now, we know that antidepressants have a big impact upon the quality of sperm. So these aren't things that we can do a huge amount about at the moment, but it is important to be aware of what your clients may be being exposed to on an environmental level. So it could be things they're being exposed to at work. Some of the things I talk about are things like male clients I had a male client who was an artist. He had very poor semen analysis results, and what we discovered was that he'd been working on a piece of artwork that involved lead. He'd been doing some stained glass work, and the lead had had an impact upon his sperm. So be very questioning, be very forensic in your questioning when you are working with male clients. You need to think about what they may be being exposed to. One of the other things we talk about is laptops on laps. They get hot, they produce low levels of radiation. Sperm are the smallest single cell in the body, and they are very vulnerable. So they're vulnerable to radiation, and they most definitely don't like heat. Okay, so that's a big factor. There may have been some trauma of some kind. Now that could be either physical or it could be emotional. So there was a student I was working with, and she was working with her case study, and she was working with the testes reflex point, which was quite swollen and seemed enlarged. And when she spoke to the client about it, he said, "Oh yes, I had a football injury. I got kicked in the testicles, and I've got one testicle that's really swollen." And the interesting thing was that he hadn't consulted his GP. So she sent him very quickly off to see his GP, who said, "Ouch," and referred him on for some further investigation. So we know that trauma will be having an impact upon his sperm quality. So really important to be aware of physical traumas and also emotional traumas. So I think I've spoken about this in a previous seminar, that I had a client who came with very poor analysis, and he came to see me in April. And when we're looking at semen analysis, we have to be aware that we're looking at sperm that were produced 3 months previously. 90 to 100 days is the time it takes for sperm to develop. And I said to him, "What happened in January?" And he was very shocked because he'd been involved in a climbing accident where his colleague was killed. And that emotional trauma showed 3 months later in his semen analysis. So be very aware of what traumas might be having an impact. Infection, we've already talked about. Infection in the reproductive system will have an effect upon what happens for our males' semen analysis. Systemic fever, so if men have had flu, again, you will see that represented 3 months later, 90 to 100 days later, in their semen sample. We also know that stress has a big impact. Stress interferes with how the endocrine system works. So the endocrine system, if you're disrupting what happens with the endocrine system, it can disturb FSH, LH for men, and therefore that has an effect upon testosterone, and testosterone is responsible for the production of sperm. So stress is a huge factor, and if you have men who are very stressed, you need to be addressing that. The other thing that could happen is anatomical anomalies. So you may have men who have things like hydroceles or varicoceles, so varicose vein of the testicles, fluid surrounding the testicle. Again, those things need addressing because they will be affecting the quality of the sperm. Okay, so some possible causes of poor sperm motility to contemplate. Sperm motility is the ability for the sperm to swim effectively, and if they can't swim very well, then they're not going to get very far, because they've got a very long journey, not only through their own reproductive system, but through the female reproductive system as well. So it could be psychological. The interesting thing is that if you have males who are having to produce semen samples, it can have a hugely profound psychological effect upon them, in that it becomes very difficult for them to produce that. And for some, culturally, it is a big taboo. Masturbation is a big taboo, and so we need to be very sensitive and aware that that could actually be reflected in their semen sample. The collection method, so it could be the container, and we know that cervical mucus affects sperm, particularly if it's hostile. Most of the time it's acidic, so that has an effect upon the quality of sperm. But certainly if they're not using a standard container, then it can damage the sperm, and then we're going to see poor reference ranges. Transport of the sample. Now, one of the things to say here is my preference is always for men to produce their sample in situ, so at the clinic, rather than produce it at home and then have to transport it to the clinic for assessment, because sperm need to be assessed within 75 minutes of being produced. If you have produced the sample at home, then what is going to happen is that you're going to have to be very careful about the time it takes to get to the clinic, to park, to find the lab, to pass it over and pass on all the information that goes with it. So it is really key that as frequently as possible it is produced at the clinic and not at home, because exposure to cold, sunlight, too much heat will damage sperm, and we really need to make sure that we've got the best sample that we possibly can so that it can be assessed properly. Is infection and or high fever. Both of those things can have an effect upon quality of sperm motility, so again, very much need to be addressed. Okay. Sperm vitality is how alive they are, and we need to have lots of sperm that are alive for a good sample, right? So one of the things that may affect sperm is having poor cervical mucus, and we're talking in terms of natural conception here. So sperm do not like an acidic environment. They like an alkaline environment, and there's only this very short window when women are producing lovely fertile cervical mucus that allows sperm to survive. Most of the time cervical mucus is too acidic and therefore sperm die. So one of the things we need to think about is, are our females producing good, healthy, fertile cervical mucus, and that we covered when we looked at ovulation charting, but it's really key. We know that sperm don't like heat, so we need to have males that are keeping their testicles cool, so nice loose fitting clothing, and they're not cycling too much, they're not wearing lycra and keeping sperm close to their body. We need to have nice, not tight fitting jeans or lycra, but nice clothes that allow cool air to circulate. Testicles are outside of the body for a very good reason, and that reason is to allow them to be a degree or two cooler than the rest of the body. Fever we've already talked about. Having a high fever can cause a problem. Varicocele are varicose veins of the testicles, and they cause heat and inflammation and damage sperm, so they do need addressing. Obesity, so being overweight, again interferes with how the endocrine system works, and also affects, it causes heat. So we know that sperm don't like heat, and we also know that having a disturbed endocrine system will interfere with the production of sperm. We've already talked about environmental factors. Some genetic disorders can contribute to sperm vitality, and that is a whole topic in itself, so we're not going to really go there today, but it's important to be aware that there are genetic disorders that can impact upon sperm quality. And anti-sperm antibodies, so basically these are antibodies produced in the seminal fluid that actually damage the sperm, and usually as a result of infection, and there are specific tests in a more detailed semen analysis that allow for assessment of this, and certainly if you've got males with issues, I would recommend that they are tested for anti-sperm antibodies. So some causes of poor sperm morphology to think about. So morphology is the formation of the sperm. So if you remember when we were looking at World Health Organization reference ranges, the reference range of this is 4%. So 96% of the sperm can be damaged and of no use whatsoever for this to be classed as a normal sample. But there are things that we need to consider when it comes to morphology. So increased cytoplasmic droplets. Now, cytoplasmic droplets are little droplets that are attached to the sperm as they mature, and once they are mature, the droplet is no longer required. So if in semen samples we're seeing increased cytoplasmic droplets, it means the sperm aren't maturing properly, and it can affect morphology. Heat, as we've said already, also causes morphology issues. Fever, because that produces heat. Varicoceles we've already talked about. And stress levels again can cause problems with morphology. Okay. So let's have a little look at some statistics. We were talking about sperm morphology. So in 2000, a semen sample with fewer than 15% of normal formed sperm were classified as abnormal. And as I was saying, that reduced to 9 to 11% and now stands at 4%. It's just, I just find it quite extraordinary, and it does say so much about male fertility. One of the things I'm going to say at this point is we're just coming towards the end now, so if you've got questions you want to ask, please do fire away. Harriet is waiting to take your questions, and she will be noting them down, and then we will discuss them at the end of the webinar. So don't be afraid to ask questions. None of them are silly. We're always happy to answer them. So do fire away. Okay, so let's have a look at pH. Optimum pH for semen analysis is between 7.2 and 8, which, as I was saying, is alkaline. Sperm don't like acidic environments. They like it to be between that reference range. So less than 7 would be an acidic environment, and that would be perhaps indicate an absence of the vas deferens, so a little tube that carries the sperm up to where they should be. And anything greater than 8 would be alkaline, and that would indicate an infection. So either of those things would need further proper investigation. Okay. We were also talking about anti-sperm antibodies, so immunological response to infection. So the sperm are identified as foreign bodies and killed. The sperm start to clump together. You see this little grouping of sperm. Of course, they can't get anywhere. They're not going to swim very far, but it does mean there's infection present that can be treated very simply with a course of antibiotics quite often. Cytoplasmic droplets, we've already talked about this, so an excessive number can indicate poor sperm maturity and requires further investigation. What you may see if you're looking at semen analysis results is what's called the teratozoospermia index. So it is a measure of sperm morphology, so how many are well formed. So the sperm may have between 1 and 4 abnormalities, so that includes head defects, neck and mid-piece defects, tail defects, and the presence of these cytoplasmic droplets. The reference range should be below 1.6. Okay, so you may see that if you're looking at semen analysis. Okay, so how do we treat them? One of the things to be aware of with men, because of the length of time that it needs for sperm to develop, from production to maturation to being ready for ejaculation, is about 10 to 12 weeks. So with a normal sample that is poor, you would want to work with men on a weekly basis for 8 weeks as a minimum. And what we're going to do is you would use this protocol, which is listed in the book. We have lots of protocols for men, including protocols for any underlying condition. So if, for example, you did have a male that had a prostate condition, you would treat that and use the weekly protocol for them. So if we have men with poor semen analysis, we would want to stimulate their endocrine system and their reproductive system, because we want to encourage the production of more sperm. So the reproductive stimulation would include testes, prostate, and sweeping the vas deferens. We would also work both the testes and the pituitary together, because you want to make sure that the testes and the pituitary are talking to each other effectively. Okay, pituitary sends testosterone messages to the testes, and that's what we need for good sperm production. Pelvic lymph node sweeping, because quite often there is congestion around the pelvic lymph nodes, and we want to make sure that that we clear that congestion. And then some lovely work just to support them emotionally, solar plexus balance and pelvic hold. Okay, so that is for a standard poor semen analysis. Okay, if you have men who have a poor sperm DNA fragmentation. Now the interesting thing is, as we were saying earlier, you can have males who have very normal standard semen analysis and everything looks fine, but it's taking them a long while to conceive, or repeated miscarriage, early miscarriage, or non-implantation issues with IVF. It may be then that the sperm DNA is an issue. Professor Sheena Lewis did her original study, which is quite some while ago now and has been updated. They took, I think it was 240-ish couples who had unexplained infertility, and looked at the sperm DNA for those couples. 80% of the males had elevated levels of sperm DNA fragmentation. Now what that means is that the levels of DNA fragmentation were above 24%. Below 24%, the egg can cope with it and repair the levels of fragmentation. But anything above and beyond that, it can't cope, so it causes a problem and you get damaged embryos that are being formed. Therefore, what that means is we need to work for much longer period of time with our males. So you would work with them for 12 weeks before they went for a reassessment using these techniques. Okay, so endocrine stimulation, reproductive stimulation, testes pituitary stimulation, testes bilateral stimulation, because we really need to increase the volume of sperm that are being produced, pelvic lymph node sweeping, because there will be congestion and damage, solar plexus to manage their feelings and emotions, and also working with the adrenal gland, because you want to remove or reduce the stress levels. What we know is one of the factors with sperm DNA is elevated levels of free radicals, and we really want to reduce those numbers. Okay, so it's important that we work with men to improve the levels of sperm DNA fragmentation. The exciting thing about this is that we are using medical tests to show how effective reproductive reflexology is in promoting male fertility health. And I find that absolutely fascinating. It never ceases to amaze me. We've had some of our practitioners recently who've had men with 0 sperm counts, no chance of fathering a child themselves, and what we've seen is that they've managed to get the count initially within a few weeks up to 5 million, and that means that even though they had to go through IVF, that those men could biologically father a child rather than them having to use donor sperm. And that is an extraordinary gift for any couple. So I just think that it is an amazing thing to be able to do. Okay, so just to kind of recap, we have lots of information in the book for you, and as I said, Watkins have very kindly discounted the book as a 50% discount. You will get an email this evening which gives you all of the information. If you want to come and join me for training, then there'll also be a code in the email which entitles you to a £20 discount when booking any of the courses we have, with a link to the website. And I just would like to say thank you so much for joining me. I hope you found it interesting. I hope that as a practitioner you find this is information that you will find useful in terms of supporting your male clients. It's really important that we engage with them. It's really important that we don't marginalise them, and it's really important that we work with our men to help our couples become families and not remain just couples. So thank you very much. I'm just going to wait for Harriet now. I think she's going to come and join me to see if we've got some questions for you. So I will introduce Harriet.
Hello.
So this is Harriet Coombs, who teaches alongside me, and so you will see when you look at the website that some of the courses are taught by me and some by Harriet. She's going to fire away with some questions.
Well, we've got a few questions here, Barbara, that have been sent ahead. Women have their blood hormone picture done, but there doesn't seem to be the equivalent for men. They just have a semen analysis. Is that right?
Okay. There are no really structured tests of blood hormones that will tell us an awful lot about males. The ones that you're most likely to come across might be FSH, LH and testosterone, but they really aren't tested unless they think there is a major issue. The best test is a semen analysis, because that shows us exactly what is happening with sperm.
So once a man has been and had the semen analysis with the NHS, how would they then be referred to an andrologist to have further testing? How would they know they did that?
Okay, that's a really big question actually, because unfortunately if they're just having a basic semen analysis through their GP, then they won't, unless they decide to seek something further themselves. And that's where we come in as practitioners, because we have access to and a referral pathway for our males to have more detailed semen analysis. So it is key actually. Yeah.
And is it true that most semen analysis is a visual observation that's done visually rather than by any computers or anything?
Yes, you will find that part of it is computerised. What tends to happen is they take a sample of sperm and they will look at them using computerised microscopes, but it is a visual observation of what those sperm look like, how well formed they are, and how well they are swimming. So it's visual observation.
Visual observation. And when should a man go for a test such as the sperm comet test? Again, what stage should he go and have that done?
Okay, so the sperm comet test is not a cheap test, and it is something we would only recommend if clients have been trying to conceive for a lengthy period of time, and I'm talking probably 2 years or more. As I've said previously, if they've had a number of early miscarriages, and probably I wouldn't leave it any more than 2, and also if they have had sort of failed IVF cycles could be an indicator that they've got elevated sperm DNA fragmentation.
Okay, and one last question. Could you treat a man who's had cancer?
Okay, that's an interesting one. You can treat males who have had cancer, but you wouldn't want to treat them within 2 years of them having completed any of their treatment, including chemotherapy and radiotherapy, because we know that those things have a very detrimental impact upon DNA. So it doesn't matter what kind of cancer it is, you would want to make sure they're 2 years post-treatment. that they are clear, that their consultant is happy for them to try conceiving, and I most definitely would send them for both a detailed semen analysis and a sperm comet test to make sure all of that was fine before we started treating them. So I think that's a really good question.
And that's it, thank you.
Okay.
Yeah, thank you very much.
Thank you. Thank you, Harriet. Thank you, all of you, for joining. I hope you found it really interesting. Don't forget to watch out for your email at the end of this evening. And if you've missed any of the other webinars that we have done, you will find them on YouTube under the Watkins books. I don't know what part you'll find, but you'll find them there. And if you do have difficulty, then you can always email me via our website, which is Sperm Reproductive or serumnaturalfertility.co.uk, or you can email me directly at barbara.serumtraining@gmail.com, and we're happy to answer any questions you might have. So thank you very much indeed for joining me.
There we go. That was great.